I'm Tommaso Simoncini from Pisa, and I have a terrific honor today that is to chair this webinar. The title is Lessons from the Global Consensus on Testosterone for Women. And I do think that this is one of the sessions that I will certainly listen, not just because I'm a chairman, but because I'm really eager to see the contents and to hear the contents by two great experts in the fields, Professor Susan Davis and Professor Johannes Bitzer, that I will introduce in a few seconds. So this webinar series is organized by the International Menopause Societies as a way to connect with the membership and with people around the world interested in menopause medicine and women's health in a broader sense. And the title of this lecture, this webinar, was chosen because this is really the example of the collaboration of not just IMS, but a series of scientific societies that last year joined to put together the evidence that is really complex and to some extent scanty on the relevance of testosterone in physiology and particularly in terms of as a therapeutical agent, which is a really interesting concept. So today, the two lectures and the discussion that will follow with Susan Davis and Johannes Bitzer will certainly be of a great help to us to put this issue in the right perspective. I'd like to acknowledge before going to the presentations the unrestricted support that IMS has received from Bezen's Healthcare. This was an unrestricted educational grant, thus Bezen's Healthcare had no role in the selection of the topics or the speakers or has not seen the content. So it's really supported by the industry, but without any interference. So I'd like to thank Bitzer for making it difficult for a society like IMS to be able to connect with the membership in these difficult times. So I'd like to go straight to the webinar because it's time to give space to the two speakers. And I'd like to introduce first Professor Susan Davis, who's going to introduce the topic, presenting the results of the global consensus statement. Professor Susan Davis needs very little introduction, I'm sure. So, but it's really my pleasure. She's not just really a leader in science, in endocrinology and gynecological endocrinology and women's health throughout the world. She's held a number of relevant positions worldwide. Right now, she is the president of the International Menopause Society. As you may know, Professor Susan Davis works in Australia and Melbourne at the Monash University Women's Health Centre. And she leads a number of programs and she's the author of an infinite number of publications. She has more than 400 publications, all in the field of women's health. But she's contributed specifically throughout the years a lot of original information on the physiology, on the clinical role, and on the therapeutical role of androgens in women. So she's really the best person to give us the first of the two lectures. And having said that, I'd like to give the word to Susan and to thank her for being here with us today. Susan, I'll stop sharing my screen so you can share yours.
Thank you very much, Tommaso, and I will now do that. Thank you for that generous introduction, and hello to everybody around the world at all different time zones. I'm delighted that so many people are tuning in. So first of all, I will share with you my disclosures, which are listed here, and the majority of my research funding is actually from competitive grants. So what I'm going to go through briefly is testosterone efficacy, safety, and a bit of information and tips on prescribing. So as Tommaso has explained, the a lot of what I'm going to talk about comes from the global consensus position statement on testosterone for women. Now, this position statement was developed at a meeting in Berlin last year at EMAS. And you can see here on the picture that I'm showing you, a number of the people that participated, including Professor Bitzer, who's on one of our speakers, and a list of the number of societies that participated in this truly collaborative project. A lot of the outcomes were based on a systematic review and meta-analysis that was published in Lancet Diabetes and Endo, and Rakib Islam, there on the very left, undertook this review. So let's do the bottom line first. And if this is the only thing that is remembered from this presentation, it's important. The only evidence-based indication for treating a woman with testosterone at this present time is for the treatment of women who are postmenopausal, who have low sexual desire with associated distress, or HSDD, hypoactive sexual desire disorder. And the available evidence supports a moderate therapeutic effect. There are insufficient data to support the use of testosterone for any other symptom or condition or for disease prevention. Now, I'm not going to give a talk on sexual desire dysfunction, but really to highlight that it is one of many aspects of sexual dysfunctions. And when we talk about HSDD or hypoactive sexual desire dysfunction, we're talking about loss of spontaneous desire, responsive desire, and inability to sustain desire. So what did the analysis of all the available data showed? Well, I'm going to show you a series of slides now that look like this. These are forest plots. These are the studies on the left. The number of participants in different studies are these numbers. And what you can see here is the mean difference, or the standardized mean difference. So if anything on the right favors a benefit of testosterone over placebo, here in this diamond is the overall beneficial effects that shows that the available data shows that testosterone is more effective than placebo on increasing satisfying sexual events in women with HSDD. Here you see the same sort of scenario, and you can see sexual desire. These are the mean difference, the standardized mean difference from all the studies, over 3,000 women in these various studies, more like nearly 4,000. And you can see here, the overall effect favors testosterone. We see the same for arousal, and here this is the diamond, the overall effect favors testosterone, and orgasm. Now these are all studies of women who are postmenopausal with HSDD, a beneficial effect of testosterone. And we see that it's flip sides. This is favors testosterone over here, sexual distress, and the overall clear benefit is favoring testosterone therapy. And the studies were broken down into surgical, natural, and surgical and natural combined, but here's the general effect. So most of these studies reported on sexual function in women with HSDD or generalized sexual dysfunction. Therefore, the recommendations are very specific to these women and should not be generalized to other subtypes of sexual dysfunction. And I would like to highlight that the task force concluded that there was insufficient data to make any recommendations regarding the use of testosterone in premenopausal women for sexual function or any other outcome. Now, this is a study that literally has been published today. It's a study that we have done where we have looked at associations between androgens and sexual function in premenopausal women. And what we found, which is consistent with the recommendation I just shared with you, is that although there are associations between androgens and sexual function in premenopausal women, these associations are very small, modest. And therefore, the measurement of androgens in women, in premenopausal women, offers no diagnostic use in terms of assessing their sexual dysfunction or function. And this all ties nicely together with what I've just said, there is lack of data for the use of testosterone or androgen replacement in premenopausal women. We looked at other indications, and I've listed here the fact that available data do not support an effective testosterone therapy on any of these outcomes, mostly because there is just insufficient data. I'm going to show you some of the data, but I don't have time to go through all of it. If we look at lean mass and total fat, so effects of testosterone compared to placebo, I want to highlight here that the number of women in these studies was small. Remember, before I showed you that there were nearly 4,000 women in the sexual function studies, there are about 150 women looking at lean mass, and there was no benefit of a testosterone over placebo. And here again with total body fat, no benefit of testosterone over placebo. If we look at depressed mood and low well-being, the data, there were many more women in the studies of psychological general well-being, but there was no benefit of testosterone over placebo. And similarly for depressed mood, no benefit. The women in these studies were women with HSDD, not women with low mood or depression. What's also been very timely is this paper has only just been published from Karen Miller's group in the US. And they looked at the value of giving testosterone transdermally, a conservative dose, to women with refractory major depression. It's a very elegant 8-week randomized placebo-controlled study. And they found that for women with major depression, adding testosterone, although well tolerated, was not more effective than placebo in improving symptoms of depression, fatigue, or sexual dysfunction. So this confirms the work that I've already presented. So testosterone improves sexual function in women with HSDD, but we concluded that the doses that need to be given should approximate physiological testosterone blood concentrations that are seen in premenopausal women. And we looked at safety. And these are the aspects of safety we considered. If we looked at alopecia, clitoromegaly, and voice change, there was no effect of testosterone, but women who received testosterone were more likely to experience acne and increased facial and body hair growth. A few studies reported on BMI, but what was more significant is the larger number of studies that reported, or the large number of women in studies that reported in change in weight, and testosterone was associated with a small increase in body weight compared to placebo. Oral testosterone has adverse lipid profiles and cannot be recommended, whereas non-oral testosterone has no significant adverse effects on lipids, and when given as a treatment, we prefer to give non-oral testosterone. There's no evidence of an increase in mammographic density. Testosterone in the short term does not appear to impact breast cancer risk, but there is insufficient data with respect to the long-term breast cancer risk of giving testosterone therapy. I'm not saying that there's a concern, I'm just saying we don't have enough data. And testosterone should not be used to prevent breast cancer. What is very reassuring is that in the very large number of women included in studies, there's no evidence of any serious adverse effects with treating with testosterone. So back to the patient. Women actually are bothered by sexual dysfunction. It's not a construct of pharmaceutical companies looking for a drug to give women. It's something that bothers women and for which women do seek out treatment. And Professor Bitzer is going to talk a little bit about the assessment, whereas I'm really just talking about testosterone therapy. So when an appropriate female testosterone preparation is not available, what the consensus group agreed to was that approved male formulation in a fractionated dose should be used. And this is because if a male formulation is approved, we know that there's evidence that the formulation contains exactly what it says it contains, and it is absorbed in a way that's been studied. But any testosterone preparation that results in supraphysiological blood levels should not be used. Sorry. Compounded bioidentical testosterone cannot be recommended because there is simply no evidence for efficacy and safety. Compounded therapy should only be used when no approved formulation is available. And I'm not aware of any countries where there isn't even a male formulation that's approved and available. So really there is no role for compounded therapy. You need to explain to your patients that she's having a trial of testosterone therapy of 3 to 4 months once you've diagnosed HSDD and agreed to treatment. Now, I'd like to highlight the fact that when you use a physiological dose, the effects are not immediate. You need to explain to your patients this is placebo and active therapy, that it can take 8 weeks before any benefit is even seen. The maximum benefit is seen at about 12 weeks to 16 weeks, and that no benefit is seen beyond that level after 6 months. So you need to explain that the therapy is a trial for 3 to 6 months. You should measure baseline testosterone concentrations, and I'm going to briefly explain a little bit as to measuring and how you should measure. This is not simply to diagnose androgen insufficiency because the physiology of testosterone is complex due to binding to proteins and because testosterone is made in peripheral target tissues from DHEA and androstenedione. Blood testosterone levels do not equal tissue levels or tissue action. This is because of the complexity of steroid hormones in their actions. They either bind to cellular DNA receptors, there are membrane-bound receptors, there's non-genomic actions of testosterone, and all the effects are modified by this complex array of other proteins in cells and other steroid concentrations. So simply measuring a blood level does not tell you what's happening in the tissues. So testosterone should not be measured to make a diagnosis, but should be measured to avoid treating women with unexpected high levels and to monitor therapy. There is no biochemical definition of androgen deficiency syndrome. And when you measure testosterone in women, you must be aware that a lot of assays are imprecise at low levels seen in women. Immunoassays cross-react with other steroids, and normal ranges are often based on small number of women. So when we look at low levels of testosterone, all immunoassays correlate poorly with gold standard. So ask your laboratory how they measure testosterone, understand the reference range that they have and how it was established so that you know what you're actually measuring when you measure it in your patients. After prescribing testosterone, check blood levels after 3 to 4 weeks because women are usually applying a transdermal product and you want to check that they're not over-treating themselves. If they are, give your patient a call and tell them to reduce the dose and retests. Always review your patients at about 12 weeks. And if there is no benefit by 6 months, as I've shown you, stop the therapy. If a woman continues beyond 6 months, you should continue to monitor her hormone levels regularly as long as she keeps using the testosterone. DHEA is not recommended as an alternative systemically because there is no evidence that it improves sexual function over placebo in women with HSDD. Vaginal DHEA is effective for women with dyspareunia, but should not be used with women without dyspareunia because there's no evidence of benefit. So in conclusion, HSDD is diagnosed after excluding other primary causes, and Professor Bitzer is now going to talk about this. It is not diagnosed by a low blood testosterone level. Testosterone therapy that results in blood levels similar to those seen in premenopausal women can be trialed to treat HSDD in postmenopausal women. and presently there is no other reason to prescribe testosterone for women. I'll stop there and hand it over to our host. Thank you.
Well, thank you, Susan. That was a wonderful overview, and I think you made it very clear how complex was to put all this information together. So it was really a major effort, and you showed the panel of persons who participated in the panel of societies that actually participated to this very contentious topic. So before introducing Professor Bitzer, who's coming next, an housekeeping information because I missed it, but I see that many of the audience is starting to use the Q&A tag. Q&A stands for question and answers. So feel free to drop a question in the Q&A space. And after Professor Bitzer's presentation, we will select the most enticing ones and to start a discussion between us. So it's my real pleasure now to introduce Johannes Bitzer. Johannes is a very good friend of mine, as much as Susan, and he's the ex-chairman and now professor emeritus in Basel University in Switzerland. Johannes has been one of the leaders and the experts in the world in both contraception and sexual medicine, and I'm sure you have listened to one of his or more of his beautiful presentations. Johannes has been president of the European Society of Contraception and the International Society of Psychosomatic Obstetrics and Gynecology. He's been also involved with many societies, including the International Menopausal Society as a board member. He's published a whole lot of original information throughout his career, and he's editor-in-chief of the European Society Journal of Contraception and Reproductive Health right now. So Johannes, I'm sure you will now touch on the clinical assessment and how we can manage with these persons, with these women with hypoactive sexual desire dysfunction. Johannes, up to you.
Thank you very much, Tommaso. Can you see me? Yes.
Yes, we're there.
Thank you very much. Well, it's a great pleasure to talk after Susan because she gives such a wonderful and comprehensive overview about the subject of testosterone for women in sexual medicine. One of the problems, of course, and Susan mentioned that, is that hypoactive sexual desire disorder and also arousal disorders to a certain degree are patient-reported outcomes. They are not something you can measure objectively. I mean, there are questionnaires, you know about FSFI and others, but in clinical practice, this is not so helpful. So we have tried to develop some sort of a semi-structured interview. What are the main questions you would like to assess to help you to get a little bit into the brain of the patient? What is she really experiencing? Now, I have no financial relationship to disclose in this context. Now let's start with this patient coming in. Doctor, I have lost interest in sex. Usually this is not done at the beginning of the consultation, but in my experience, it's usually just before the woman wants to get out of the door. She turns around and says, well, what about, I've lost interest in sex, is that normal? And I think this is an important moment where you need to join with the patient and to make a first step into what we call in psychosomatic and psychotherapy a shared reality. So you may say, this is an important issue. Can you tell me more about it? And if it is in the last 5 minutes, you can say, this is an important issue. I would really want to discuss that with you. And I would really want you to come back. I think we should talk about it. That's, by the way, an important point, because if she doesn't come back, she may not really be motivated to do something about the problem. So the rationale behind this sentence, you could say, behind this type of communication is you acknowledge the importance, And it also leaves a presentation of the individual experience. Take a little bit the time to encourage the individual story, because that already gives you a lot of insight into the individual meaning of this loss of interest. She may say, you know, for me, it's not so much a problem, but I'm afraid I'm losing my husband. You know, that's a different meaning of this symptom than the one who says, well, really, I had such a very good sex life, and now it's really gone, and I'm frustrated because I had such good sexual experience. So you get some insight into what the meaning of this loss is. And then another important question is, as I mentioned before, if I say HSDD, I have a certain concept in my head. And maybe it's different from Tommaso, it's different from Susan, it's different from different patients. So really, it is quite important to ask, how did you notice this loss? How did you realize that there was this change? And this can help you to understand the different dimensions of the loss. We call that in psychotherapy and psychosomatics the individual phenomenology of the loss. In medicine, phenomenology is a new philosophical approach. If the patient has difficulties to find words, you can offer answers. Is it that you don't respond to the partner stimulation? Are there no spontaneous fantasies anymore? Did the images that were attractive and stimulating lost their appeal? So this has also something to do with the differentiation between responsive loss of desire and spontaneous loss of desire. I'm coming back to this in a minute. So that would be what we call in communication the open, guided questions. It's not about yes or no. It's again an invitation to give more information, but with a theme which is given by the doctor. We have more open, guided questions. Now, how did your sexual life look like when you were satisfied with your interest and desire? You want to know, did she enjoy sex? Did she get aroused? Could she reach orgasm? How often did this happen? Now, this helps you to understand, is this a very sort of long-standing problem that has been aggravated? And especially, did she have a good sexual function, satisfying individual sexual function before? Because these may be important resources to build upon during the testosterone therapy. And this can also help you a little bit to understand what we call in sexual medicine the ideal scenario. What would be the ideal sexual scenario you would like? And then you would ask, when was that? Was that before the children came? Was that before the menopause? Was that in a different phase of your life? And that gives you a first hint of what we call the sexual history. And it also helps you to understand what are the possible factors that have contributed to this change. Actually, for example, if the patient notices herself a rather sort of dramatic or intensive change around menopause, that may be really an important factor, although we know that, of course, testosterone declines earlier, but it is important to understand that. Another open-guided question would be, what did you try yourself to find again interest in pleasure? And in this context, you can bring in masturbation as something very normal. Is masturbation a way? So you want to understand if this patient is really looking proactively for solutions, and how does she do it? And also maybe how does she feel about solitary sex, which could also be a resource to refine the sexual response of the body. And then another important or useful question is, do you sometimes engage in sexual activity with your partner without feeling interest or desire, for example, to please him or her? What do you experience then? And our experience is that to this question, it is quite frequently that women respond. They somehow have lost the spontaneous interest, but when when they are invited to participate in sexual activity, arousal may come back. This is one of the myths which we also in sexual counseling try to address. Sex has not only to be spontaneous. You can make an appointment for sex with your partner. Because if the patient still feels aroused or having an orgasm, that may also be an important resource during the treatment. And then finally also to see a little bit the motivation for the treatment, to see the possible background, and to get into what we call the patient hypothesis. Now, you can say, we know that the loss of interest in sex can have multiple causes or contributing factors. Biological factors, hormones, stress, family, whatever. What do you think contributes maybe the most to your problem? Is it a problem with do you think it's a problem with the partner? Do you think it's hormonal changes? Do you think it's life stress? Do you think it's problems with your body, dissatisfaction, or do you see other factors? This is quite important because if your hypothesis is very different from the patient's hypothesis, it may be quite difficult to get a good collaboration and to get a good working condition. And I think with these questions and this semi-structured interview, it doesn't last so long. You can already quite well differentiate between those patients where there is an indication for testosterone therapy and who may be motivated also for taking this therapy in the context of an ongoing also sexual counseling, in my view. And it also helps you to exclude those patients where it becomes clear that it is much more a relationship problem, that it is much more a life event problem, and that may then also, of course, help you to see that this is not an indication for testosterone therapy, but that the other issues should be addressed before. Yeah, thank you very much. That was my little insight into practical sexual medicine.
Well, thank you, Susan. Thank you, Johannes, for your very nice lectures. I really, Johannes, I think you gave a very, very practical way, which I think was really appreciated by everybody. From myself, first of all, on how to approach and how to develop the discussion in the real world clinical setting with our patients. We have been flooded by questions, actually. So it's I would also have questions for myself, but I think it's much better to give space to questions from the audience. There's a series of questions that I would like to kind of join, and I think I'll try to put a question to both of you. By looking, I'll try to synthesize what I've seen by reading the questions. There's a lot of questions on a very technical issue, which is how to dose, what products should be used to replace testosterone. And there's other questions that look more into how long therapies should be continued, or is it safe to continue? And there's special types of persons who should be more carefully looked at when being prescribed testosterone. So I think this makes me feel, these are also in part my doubts as well. So there's it's still very difficult to use, so we do understand the role of testosterone. Susan, you gave us a very good overview, but it's still very difficult for all of us throughout the world, based also on the difference in products, to decide how we should actually prescribe and how long with what products. I would like to ask you in a very general way, to Susan first and Johannes afterwards. What do you do in your clinical practice? With what products do you select? What's your strategy to tailor the therapy? Susan, would you like to start?
Yes, so we're very fortunate in Australia in that we have a product that is specifically for women. It's a 1% testosterone transdermal cream, and we have published pharmacokinetic data with it. It is also available now in the UK, I believe, and my understanding is that it's also possible for people to prescribe it and obtain it through prescriptions for their patients in other countries from Australia, if you can import testosterone. For countries where you cannot access this, generally we work on the principle that women's circulating blood levels are about 1/10 of those of men. So if you start with a fractionated dose, about 1/10 of the dose. So if you're using, say, testosterone that comes in as a gel in a sachet, many people will load it in, get the patients to load it into a syringe. And if it's a 5 ml syringe, they use 1/2 ml transdermally daily. And that's usually the best way. But whatever you're giving, you must measure blood levels, and you can titrate the patient's dosing according to the blood levels. And it doesn't matter how long the patient keeps using it for, you must keep measuring levels every few months. There's no limit on the duration of therapy. We did a retrospective study of women using it for up to 20 years, and there was no evidence in that study that there were any concerns. I can see questions like, can you give it to women who smoke? Interestingly, women who smoke tend to have higher blood testosterone levels, but testosterone is not prothrombotic, so you can give transdermal testosterone to women who smoke. And our study, we did a large study of 800 women of testosterone versus placebo transdermally in women not on HRT. So women do not need to be on estrogen in order to have testosterone therapy. But again, the most important thing is you commence the person on testosterone, and then you follow up by checking their blood level to you're not checking it to a target treatment blood level, you're just making sure that they don't get a supraphysiological level. I'll let Johannes comment.
Would you like to add something on your European perspective?
Yeah, well, I think one of the practices right now is, as Susan has mentioned, is taking testosterone and dosing it at 1/10. Some time ago, we also practiced giving DHEA, but following the testosterone levels. And we could see that, I remember 2 very interesting cases in that case, one woman was premenopausal even, who noticed a really sort of a dramatic decline in desire without psychosocial reasons. It turned out that her testosterone levels were rather low. I agree, of course, there is no cutoff. But anyway, then I gave her at that time DHEA as a source for testosterone, because we didn't have Intrinsa anymore, and so I thought let's have a try. And interesting enough, it really improved, and I controlled testosterone, and it was still in the normal range, but it had increased. So that was for a time a certain practice, and I think it's still practiced in some parts of Europe, that you give DHEA. And I don't know how many people really then follow up on what happens with testosterone. But yeah, now the trend is much more towards titrating with testosterone, and also waiting for the Australian androgen.
Well, one of the other questions that I have noted, and I think it's more of I think it's a medical practice question. There's which I liked a lot. So a couple of persons are asking if the person that I have in front of my desk is not actually complaining or actually raising the issue of sexual complaints or sexual life, and she's after menopause, so I do expect that this may be happening. Should I raise the issue with them? So Johannes, so you've shown a very nice way to respond to an active, a proactive question by the patient. But do you routinely to elicit the issue of sexual dysfunction or sexual problems with your patients?
Well, that's a very good question, because we all know that it is in many countries in Europe and cultures, asking about sexuality is an intimate issue and may be perceived as very invasive and not appropriate for the place. What our practice has shown a little bit is it's not good if you have a patient you know for 10 years and you suddenly start asking her about her sex life. That may be something strange. If you ask about sexuality, you have to put it into context. You can say, now you have entered menopause. Did you notice any change in your sexual life, in different aspects of your sexual life? And I think what is quite important also, just to ask, are you sexually active? It's not necessary. Nobody has to be sexually active. But and if the person says no, and she says, and you ask, is that a problem for you? Is that okay for you? And she says it's okay for you. I think we don't have to, put people into a position that you have to have sex. But those where they respond, yes, I'm sexually active, then you can easily ask, and is everything all right? Are you satisfied? Are there any problems? And of course, in other contexts after operation, in the context of surgery or of course oncology, you can easily introduce the subject by just pointing to the fact there has been a change. Also, even starting menopausal hormone therapy, you can ask about whether there is a change in mood and in sexual life. Yeah.
And if I can just add to that, Tommaso, that I think there are two things. Our research, particularly the study we did of women aged 65 to 79, that was a big national study, don't assume just because an older woman is not married that she is not sexually active. And often that person might be uncomfortable bringing that issue up because they're worried it might be judged. But these are women, and we're talking about testosterone, but these are women who may not be aware that vaginal estrogen can deal with dyspareunia. And the other thing is that in many countries, the age group in which sexually transmitted diseases are actually increasing is in people over the age of 50 who have rekindled relationships or new relationships and don't even think about the fact that they could get sexually transmitted disease. So I think I'm an endocrinologist, not a gynecologist, but I ask this of every patient. I don't ask them. I ask them if they're sexually active, and ask them if they have concerns. And I think it's for multiple reasons that we should ask this.
I agree with both of you, and I think it's always a very sensitive problem, and the people are not as open and real. But I think that when you open up the discussion, we all agree that this is generally well perceived by most persons. I mean, it's difficult in my practice that somebody refuses the question. So another issue that is recurrent within the questions in the audience is the relationship between menopausal hormone therapy and testosterone replacement. So do you need to have both? So are we speaking about the same concept? I mean, do you need to replace both estrogens and testosterone in women with HSDD, or this is not necessary? For instance, there's a person who asked specifically, can you use just the testosterone in the absence of hormone therapy, estroprogesterone therapy, of course? Susan, do you want to address that?
Yes, so I think there are a couple of issues. Firstly, you need to determine firstly if there's dyspareunia, and if that's the problem, you would treat with vaginal estrogen first. And if you have someone who's experiencing classic menopausal symptoms, you would treat that first, because if you alleviate the vasomotor symptoms, improve her mood and anxiety, improve her sleep, the sexual dysfunction may be less of a problem. But if the question pertains to, say, a 53-year-old woman who's 2 years postmenopausal, or a 58-year-old woman, or even a 60-year-old woman, age is not relevant here, someone who's postmenopausal, no vasomotor symptoms, no dyspareunia, I would not hesitate to treat with testosterone without giving concurrent estrogen or estrogen and progestin. So this is based on the fact that we did the Aphrodite study, which we published, in which we randomly allocated women not on HRT to testosterone or placebo. Sorry, excuse me. And the study went on for 12 months, and our main outcome, apart from effectiveness, was safety. And what we found was that it was perfectly safe to give testosterone to women, postmenopausal women, without giving them estrogen or estrogen plus progestin.
Great. This is absolutely clear. The other thing that is raised by many persons is the safety issue, or more than the safety issue, also if there's categories of patients that are particularly difficult to be prescribed testosterone, particularly persons with cardiovascular risk or metabolic disorders, metabolic syndrome, obesity. One person is asking about diabetic women. So is it safe from a metabolic standpoint, Johannes? Do you use liberally testosterone, or do you admit the use of testosterone in these categories of patients? Or what are the rules of engagement that you have in your hands?
Yeah, that's an important and not so easy to answer question, and I hope Susan is helping me. I think what we know also from the consensus conference is that if we really stay in these in these physiological dosages, that the metabolic effects, especially when it comes to transdermal testosterone, and indirectly also then the cardiovascular effects, and there were no serious events, that it looks like quite a safe procedure. Nonetheless, I think I would really try to control well for all the other factors that you can influence to reduce cardiovascular risk.
Susan, would you in these categories of patients check specifically something like blood pressure or lipid levels in addition to the testosterone titration?
I think in that age group, we should really be very active regarding screening for cardiovascular risk factors.
I would agree, Tommaso, that the primary thing in people with metabolic syndrome is firstly to treat their metabolic syndrome even before giving any other therapy like hormone replacement therapy or testosterone therapy. You want to make sure that the blood pressure is controlled, that their lipid levels are controlled. This is just general. Unfortunately, for gynecologists, it's not so much your area. I'm an internist endocrinologist, so it's more in my area. But I think it is important to address these issues, and then you make a decision regarding giving testosterone. If you give it a physiological dose transdermally, it doesn't alter lipid levels, it doesn't alter fasting insulin, it doesn't alter fasting glucose. However, with the caveat that most of the studies were done in relatively healthy women. There was one study that data has never been published. It was a randomized placebo-controlled trial of people with cardiovascular and metabolic disease risks. And the data was never unblinded. There were 3,000 women randomized, but we know that the study was discontinued because the company ran out of money, but we know that the steering committee at 3 years said to continue the study, that there was no difference between treatment groups, which suggests that women with risk factors did not behave differently than women without risk factors. So relatively safe, but you've still got to be cautious.
Another safety question that is raised by many is cancer risk, particularly breast cancer. Somebody actually asks if it's feasible to provide testosterone to patients who've had breast cancer. Can you have, a very brief comment on this? Because I think this is quite clear. Susan, do you want to start?
There's no, so decades ago, testosterone used to be used to treat breast cancer. I would never give any hormone therapy to a woman after breast cancer without speaking to the oncologist first, because otherwise the woman gets confused because she's back and forwards between you and the oncologist and doesn't know who to believe. In women on aromatase inhibitors, you don't usually need to give testosterone because their testosterone's elevated because the aromatase inhibitor is blocking it being converted to estrogen. And therefore, their problem is more like their estrogen deficiency than testosterone. I think that I would not routinely give a woman who has had breast cancer testosterone, no. Certain circumstances would be the exception rather than the rule.
Great.
And I think I can add that we treat or we accompany a lot of breast cancer patients with sexual problems after treatment and during treatment. And you have a lot of different fields where you can interact and where you can try to improve sexual health. And testosterone would be not our first choice. Yeah. Mm-hmm.
Great, yes. And another setting which is significantly different is the setting of premature ovarian insufficiency. So younger women losing their ovarian function either because of spontaneous failure or because of surgery. So do you think that this is a different setting for testosterone replacement? Do you consider these patients as, say, particularly patients under 40 years of age? How do you manage this patient? Or do you follow the same rules as for the postmenopausal or after 50?
For me, absolutely. I'll start. For me, absolutely, yes. That the studies show that women with premature ovarian insufficiency have lower testosterone than other women. And this is because in premenopausal women, half the testosterone does come from the ovaries. But they still have more robust adrenal function than older women. So some of these women will still maintain a relatively normal sexual function because of their hormones. But you should at least consider it, and particularly women with iatrogenic early ovarian failure. So women who've had chemotherapy knocking out their ovaries, well, their ovaries will really not be working at all. So not everyone with POI, premature ovarian insufficiency, needs testosterone, but just like any other postmenopausal woman, it should be considered and sexual function should be discussed.
Yeah, I'm happy that I have the same opinion. I was, for a short time, I was wondering whether it should be discussed as a sort of guideline that you would have to replace testosterone or at least, think very much about it in POI patients. But I agree with you. I think for the moment we should really limit it more to those who have symptoms. Yeah.
Right, and in these patients, do you try to tailor the therapy based on the type of sexual dysfunction they have? If it's more of the desire, depression, or if it's an orgasmic dysfunction, rather than which is more common in this type of patient as compared to postmenopausal patients where there's more of a pain or other types of dysfunction. So do you use testosterone for certain settings or do you use it just because they have hypoactive sexual desire dysfunction as a whole?
You mean in the POI
yes.
patients or in general? Sorry. Did you mean in the POI patients?
Yes, in the POI patients.
Well, I think, if there is a clear sort of distinction between spontaneous desires, sexual fantasies on one hand, which are present, and really arousal difficulties, which are perceived as my body is not responding, then I think you may frequently have to combine testosterone then with other interventions regarding sexual function. So I think it is important to see the different elements of the sexual dysfunction. Of course, they very frequently interact. Low desire leads maybe to low arousal, but as I mentioned before, it's not necessarily the case. So it is really worthwhile to look more in detail into the individual picture of the dysfunction.
Yeah, Susan, do you want to add something?
Oh, I think in premature ovarian insufficiency, as in postmenopausal women, it's really important not to just go straight to hormones. There are lots of other reasons women might have sexual dysfunction. So, for example, we know that there might be drug-associated sexual dysfunction, typically antidepressants. There might be other chronic health conditions. There might be multiple other reasons. So I don't want anyone to think that Professor Bitzer and I immediately saying use testosterone. You do need to look at a whole range of causes for both young women and older women. And whether the partner's function or the whole range, the gamut of causes.
I'd like to pick one question. It was isolated, but I think it's a nice one because it's a difficult one to be answered. But you, with your clinical experience, may have a feeling. In one of your results slides, Susan, you showed that general well-being and psychological well-being tend to be improved in women with HSDD receiving testosterone. And one of the questions is about, do you know the central mechanisms of the testosterone action? So do you feel that there's some of, the testosterone per se, we know a lot of the neuroendocrine signaling of estrogens. Testosterone is a little bit less undermined, also because it can be converted to estrogens in the brain, so we don't know exactly the top. So what do you think is the brain areas or the features of brain function in women with HSDD that may be most influenced by testosterone?
We really don't know. So firstly, we did a study where we randomly allocated women. I'll go backwards. We treated all the women with testosterone, but we randomly allocated them to an aromatase inhibitor versus placebo to see if on an aromatase inhibitor, women didn't have the same benefit. Was the testosterone in the brain being converted to estrogen? And if we blocked it being converted to estrogen, would there be no effect? And we found that there was no difference between women on aromatase inhibitors and not. So that testosterone is not relying on conversion to estrogen to have its effect in the brain. So that's one thing. A number of MRI studies have tried to examine the effects of testosterone in the brain. And look, they all come up with different results. So functional brain imaging has not given us the answer. So multiple cells in the brain and networks in the brain have testosterone receptors. We don't know where it's acting or how it's acting highly specifically. We just know it's important, and it may be interacting with part of it being converted to estrogen and part of it acting as testosterone. So unfortunately, we don't have the answer.
And I think, unfortunately, also the research in, especially in men, but also in women who suffer from hypersexuality, who are treated actually, of course, with anti-androgens quite successfully. What really happens in the brain has been not elucidated. It's just a clinical experience that, of course, there seems to be a central nervous, rather strong action, but where it is located and how the mechanisms are, I don't think we know.
No.
Yeah. Well, I think I'm really thankful to both of you because you really received a lot of questions. I need to apologize if we weren't able to answer to all of the questions, but you flooded us with more than 80 questions, which makes us very happy because it seems that the topic was well chosen, and it's certainly a hot topic by all means. I think it really raised the interest. We had nearly 400 persons participating to the webinar, so it's a really successful activity. So I'd like to share one last slide before saying bye-bye, and it's this one. Sorry, I'm sharing my screen. I hope you can see the screen. And I'd like to announce that the next seminar, which will be held on August 25. And again, it's got to be a very interesting topic. So Tim Hillard will chair, and Rossella Nappi and Marco Gambacciani. So it will be an all-Italian webinar. We'll discuss VVA and of course, troubles and potential new applications. Let me also remind you of the Melbourne Congress, the IMS Melbourne Congress. Of course, these are difficult times, so we are looking forward to have more chances to meet either in person or eventually virtually, as we are doing now. So having said that, I think we had really a wonderful webinar. Susan, Johannes, you were really great speakers. And I'd like to thank all those who participated and joined, because it's a real pleasure to be connected with you, even if only virtually. So thank you so much, and I think we all hope to see you again on August 25.
Thank you.
Thank you.
Bye all.
Bye-bye. Bye all.